give a little bit of a background and sort of context. Why were we doing this? Why did we want to work with Manchester? I think is an important place to start. So from an AZ perspective, and my role within AZ is to really enable next generation clinical trials. That's my focus. And in clinical trials in respiratory disease, you have a massive issue, which Benny will know about, which is you're asking citizens who are generally reasonably well and trying to live a normal life to come into a clinic once a month to do spirometry. It's not great for the patient. It's really not great for the clinic and the resource, and actually becomes a major issue with actually getting people into interventional clinical trials. Slows down the development of new medicines to patients, essentially. And so we'd looked at trying to solve this as a problem in clinical trials, and actually have. So the technology that we brought here has been used in a whole range of different global clinical trials. We've worked with the MHRA in the UK, so the regulator here, the European Medicines Agency and the FDA, to get input into how to deliver this technology and how it can be used as a primary source of data when you're determining the efficacy of a new treatment. So that all sounds great, works really well. There's a fundamental challenge with it, though, which is that you've also always got a patient with a really clear diagnosis who's been seen by generally a consultant at the point that they're being enrolled into the clinical trial, and their first spirometry is with that consultant or with that consultant's team in a clinic. So you've got this very controlled environment where you're training a patient absolutely how to use the technology before you're asking them to take it home and use it. And so all of the training things that the team talked about, all of the logistics things that the team talked about, all of the just actually getting used to the technology, all of that's dealt with. It's dead easy. In that environment, it's a nightmare in the real world. And that's what this has shown. We were really keen on being part of this, though, because, you know, as an organisation in the UK, what we actually knew is that somewhere around 1 million citizens at the end of COVID were being treated or not treated with respiratory diseases and were lacking spirometry. That's a massive challenge. And we knew that in Manchester, as was said, there's about 70,000 people. So a really big challenge. And we worked with the team. You know, we'd previously done work with Health Innovation Manchester anyway, and working in the environment. And, you know, Binny's being very sort of playing down her role and Jenny's, but you've got Binny, you've got Jenny Hoyle, you've got Dave Singh, you've got this amazing team of academic researchers as well. So it's definitely the right place to be doing this kind of work. And so we went into the joint working agreement that you can see up here. And we delivered a set of core data packages around the analytical validity and the equivalence from the clinical trial environment, essentially to give confidence to the audience here in Manchester that there was something viable. And then we provided the spirometers. We commissioned and managed a set of ARTP trained physiologists. And this is a really important point. We have to be very, very careful as you introduce new technology that you have the right controls in place. Spirometry is a performance test. It requires, at some point, I am sure, and I'll get shot for this, that we will have AI-driven avatars who are able to coach patients, and they'll be able to coach patients brilliantly, but not now. You need to have trained physiologists, and the certification is through the ARTP. And by the way, when we do deliver the AI-based avatars, we'll get them certified by the ARTP, because that's actually how you have to have, you know, it's really, really important that you get the quality right. And for any kind of technology innovator, make sure that you actually understand what the quality standards are that you need to be able to reach. And then, I mean, you can see from this a whole set of other things that we brought in place. And I think, you know, it's been highlighted, but particularly the real importance of having people with really strong behavioural skills, but also people with real skills in patient and public engagement, and being able to work across communities to get really good insights around what citizens actually want from the service, because that's a really important piece. and also what the service providers want from a service, because that's just as critical. And as the team have said, that changed kind of around us as we were working, in that we weren't really sure actually, was this going to be a service for secondary care? Was it going to be a service for primary care? Or actually, as it turned out, being, well, it's a really good data set that will inform what becomes the CDCs. So that was what we provided. There was a load of stuff that worked really, really well. I think it's not written on this slide, but I actually just talk about team and sense of team. It was one organisation working together, even though we'd all got different badges. And again, that's really, really important in a project like this. And my thanks to the Health Innovation Manchester team for creating that sense of team across the provider networks, across what we were doing and what the technology providers were doing. I think so. That worked really, really well. And again, and Binny kind of played this down a little bit, but when we talk about the high quality clinical oversight, there was really high quality clinical oversight from the respiratory teams. But there was also, we ran into this challenge around, could we actually do reversibility, which there are different opinions, shall we say, about whether reversibility is actually really needed. And certainly some of the clinical folks that I work with will say, you know what, in 95% of cases, it probably isn't. But the gold guideline is you need to have reversibility. And actually, Binny put that really complicated flow diagram up. That's the simplest it's ever looked. It is a really, really complex process of how you move from getting some test results, it's basically, flow curves, to actually getting an answer to a clinician of what do you need to do for this individual who's in front of me today and what am I going to prescribe to them. But what you didn't really pick up, and maybe we can talk about a little bit in the Q&A, was the depth and the quality of the conversation that we were able to have with people who actually influence international guidelines about whether a particular test was needed and in what circumstances, and how to mitigate for not having it. And so, your leadership, Benny, but with Dave Singh in particular, and that's something that you can't do anywhere in the world. You have to have the environment of having, a connected healthcare system with amazing academic inputs and everything that it takes to put a program like this together. So there was a lot of real positives there, and we got great feedback actually from the end users. But I can't stress enough how you need to have that right from the start as you bring a project forward. It's not about the technology; it's about the human beings who are going to use it. And that's the really important learning, I think. And so I think I get a learning slide as well. Yeah. I'm not sure we did underestimate the technical complexity and dependencies, but if it could go wrong, it did. So, we really understood that we were trying to move from this very tightly controlled environment in clinical trials into a very broad kind of wild environment, and that were going to be challenges there. But there was a lot of challenges that sat there. The data quality, in particular the clinical grading consistency, there's definite improvements to the technology, which is moving very, very fast, but also the interpretation of data, which will continue to improve things in that space. I think one of our assumptions that was wrong, that then became a challenge, is that just because there is a problem in the healthcare environment with underdiagnosis of a particular condition, there must be aligned incentives to fix that problem. That's something that I've learned very clearly over the last 3 years is definitely not the case. And I'm sure there'll be many of you sitting in this room saying, how stupid were you to think that in the first place, Matt? But, it really is an important point that actually, understanding the complexity actually of the business environment that people are operating within to do their day jobs. And Binny again talked about the fact that we were actually having to ask people to help us on top of their day jobs as well to get this done. And we're incredibly thankful to everybody who was involved in that as well. And thank you from me for all of that. And it comes down to actually prioritising the right provider to maximise the patient and the system engagement and the patient and the system impact. And that was one of the things I think it took us probably was the most challenging thing to get right. It was challenging as well because, as people said, the environment changed while we were doing it. And actually it probably, we went through the different phases as the environment changed, and if we'd have made decisions at the start that were any different, we'd have still probably been wrong, I think. But it's really important to look at how the environmental and political impacts are playing out. And I think, it wasn't really a challenge actually, but it's just the sort of the final piece of the lesson here is there's a massive need for a really robust program management. These things are very, very complicated to do. And one of the ways that you create the sense of team that the team did is because we've got really, really clear governance, really clear escalation pathways and that level of control that actually then makes it easy to make difficult decisions. So I think, some of the engagement models and next steps. We need to standardise the partnership principles and the roles. We're looking at the delivery plan and actually just the insights that we can hand over into the system. AZ or Evinova, which is the digital health part of AZ, don't really have a horse in this race. We just want to help people to get better diagnosis. And so what we're essentially doing is handing over to the system a toolkit that can then be applied in whichever environment. And I think that's a really important piece as well for Health Innovation Manchester, that there's a data set there that can then be applied into the system. It's not about necessarily saying we've used technology X in the programme with a set of providers and therefore we need to use the same providers going forward. It's having a toolkit that people can use. I think, and it's been talked about, but I would say that the biggest thing is about continuing user-centered design for all future projects. I think whenever somebody comes with technology or a service intervention, that user design is so critical, because what you imagine is true when you're sitting in a room designing something. It's just not the case when you're out in the real world dealing with real people with real needs. And that I think is the biggest learning from all of this. I can, over a drink, tell people stories of some of the most hideous patient advisory boards we've ever done, where you find out things that you just would never have imagined. It wasn't as bad in this case. Definitely, it was all very positive, but you have to start with that. And I think making sure, again, that the governance and the communication pathways are really, really clear. So with that, thank you very much. And thank you to the whole system for everything that you did to support us.